Selamat sejahtera, salam Malaysia Madani, salam Universiti Watan, and a very good afternoon to Associate Professor Dr. Ahmad Khaldun Ismail, our panelists, Dr. Mashita Mohamed Ismail, Dr. Ruchel A. Simene, and Dr. Chu Kim Hoon, clinicians and fellow medical students. My name is Amelia Elza Thomas.
And I am Ang Zi Shi.
And we are the final year medical students in University Kebangsaan Malaysia, currently in emergency medicine posting, and we will be your moderators for today.
Welcome to the final series of the Clinical Toxinology webinar for 2024, organized by the Emergency Medicine Department of Hospital Chancellor Tuanku Mukhlis, in collaboration with the Malaysian Society on Toxinology, Remote and Renovation Consultancy Services, College of Emergency Physicians Special Interest Group in Clinical Toxinology, Malaysian Biodiversity Information Systems, University Science Malaysia National Poison Center. In this webinar and forum, we aim to explore the topic of clinical toxinology. Is it relevant to medical students? Feel free to ask any questions in the chat box. Questions will be addressed by the moderators at the end of every case. There will be a feedback form at the end of the webinar to receive the certificates of participation.
To deliver our welcoming remark, please join me in welcoming Associate Professor Dr. Ahmad Khaldun Ismail.
Thank you so much, Amelia, and our team, and also all participants. This is our last episode for our third series, so it has been running for 3 years in a row, and it's meant for medical students who are doing medical posting in the emergency department in their final year. So this is the last group of that posting, and we are in the episode 4, and hopefully this will be an enjoyable session for all students and also everybody who are listening from around the world. So you are more than welcome to join in the Q&A session in the discussion later with our esteemed panelists. I would like to also welcome our panelists for this session, and hopefully we will have a fruitful discussion for all the cases that we'll be discussing today. Okay, so I hope everybody will enjoy, and see you till the end. Thank you.
Thank you, Associate Professor Dr. Ahmad Khaldun Ismail. Ladies and gentlemen, joining us today, we are very grateful to have the panel of experts. Dr. Mashita binti Mohamed Ismail. She completed her Master of Emergency Medicine at University Science Malaysia in 2012. Since then, she has a total of 19 years of experience as an emergency physician in Hospital Sultan Abdul Halim, Sungai Petani, Kedah, Malaysia. She had received multiple times of state-level Excellent Service Awards due to her remarkable contributions throughout her practice.
So next is Dr. Ruchel A. Simene. He is a head toxicology specialty center in Northern Mindanao Medical Center, Philippines. He's also a visiting consultant at Capital University Medical Center and at Polymedic Medical Plaza at Cagayan de Oro. Dr. Ruchel completed his clinical and occupational toxicology fellowship training at Philippines General Hospital in 2020. He was also a diplomat of the Philippine Society of Clinical and Occupational Toxicology and a fellow of the Philippines Academics of Family Physicians in the same year. This year, he is a graduate of Masters in Management major in Hospital Administration. Dr. Ruchel has also successfully completed 2 research studies from 2015 to 2018.
Next, we have Dr. Chu Kim Hoon. Dr. Chu Kim Hoon is an emergency physician from General Hospital Sarawak. He completed his Master of Emergency Medicine at University of Malaya in 2019. He is currently undergoing training in the Clinical Toxinology subspecialty program in Malaysia under the Ministry of Health. A warm welcome to our panelists. Thank you for joining us today. Now, let's continue with the following agenda. We have conducted a pre-webinar survey among 34 medical students who are currently in the emergency medical posting. Fortunately, more than half of us are aware of what clinical toxinology is all about. And the first part of the survey was regarding awareness of the appropriate safety and health-seeking behavior regarding toxin injuries. Generally, most people are aware that toxin injuries are a medical emergency with various emergency services available. People are somewhat aware that following a toxin injury, one should seek appropriate health facilities. However, most people are unaware on Rex Malaysia. Next, the second part is on the knowledge about appropriate safety and health-seeking behavior for toxin injury. Generally, people are well-versed regarding sources of natural toxins and the appropriate first aid measures for acute exposure to natural toxins. However, only half are informed on the common signs and symptoms of toxin injury. Regrettably, many people might not be fully aware of the emergency hotlines and resources available for toxin-related health issues. Many people have limited understanding of the appropriate antivenom treatments for snake and venomations. The third part is on the confidence level in providing the instructions for appropriate safety and health-seeking behaviors for toxin injuries. Most people are on the fence on how to identify a potential toxin injury, to administer appropriate first aid, necessary emergency procedures in case of suspected toxin exposure, and important history details required in such cases. Fortunately, most people are aware on where one should be brought after a toxin injury. Therefore, based on our pre-webinar survey, we believe and hope that this webinar will provide our audience with invaluable insights into clinical toxinology.
Next up, we'll provide a brief introduction to our fellow final year undergraduate medical students on the topic of clinical toxinology by watching a short clip from our beloved Associate Professor Dr. Ahmad Khaldun Ismail.
Assalamualaikum warahmatullahi wabarakatuh. Saya Profesor Madya Dr. Ahmad Khaldun bin Ismail, Pakar Perubatan Kecemasan Sub-Kepakaran Clinical Toxinology, Jabatan Perubatan Kecemasan, Fakulti Perubatan UKM, Hospital Chancellor Tuanku Mukhris. Bidang toksinologi klinikal melibatkan sub-kepakaran untuk merawat pesakit-pesakit yang mempunyai gejala-gejala akibat dari bisa dan racun. Bisa dan racun boleh didapati dari tumbuh-tumbuhan, cendawan, haiwan, kulat dan juga bakteria.
Next up, we'll have 5 case presentations. After each case, we will invite the panelists for some discussions and followed by a short Q&A session. The audience can drop their queries in the chat box during each case presentation. Now, let's kickstart with our first case.
Okay, so for our first case, this is a 10-year-old Bajau boy with no known medical illness who's allegedly bitten by a black snake on his left foot at around 7 p.m. while on the way to the mosque. So the size of the bite was about half of his forearm with pudding, and the pain score during that period of time was 1 out of 10. So the patient only noticed the snake after being bitten, and he did not step or kick the snake afterwards. Subsequently, the little boy walked home and he developed 5 episodes of vomiting and pain at the bitten site at about 8 p.m. And this is 1 hour after the biting. So immediately he was brought by the parents to Klinik Kesihatan Tunku by 9 p.m. and the journey from home to the Klinik Kesihatan took 1 hour. And during that period of time, the pain score still remained at 1 out of 10. Okay, so at KK, his GCS, Glasgow Coma score was 15 out of 15, which is normal. His BP was at 115/95 millimeter mercury, which is normal as well. And his heart rate was 85 beats per minute, which is normal. His respiratory rate was 20 breaths per minute, which is normal as well, with temperature of 36.6 degrees Celsius, which is A febrile. His oxygen saturation at room temperature is 100 degrees, which is normal as well. So patient was hemodynamically stable. He did not have any new episodes of vomiting during that time. There's no systemic signs of envenoming, and he did not have any dermonecrotic features. So for his management during that time, he was given intramuscular antitetanus toxoid, and he was subsequently transferred to Hospital Lahad Datu. So during the ambulance transfer to Hospital Lahad Datu, patient developed more than 10 episodes of vomiting, and during that time, his pain score was 10 out of 10, with progressive painful swelling over the bitten region at the left foot, as you can see at the picture on the right. So his GCS subsequently dropped to 13 out of 15, but he still had good respiratory effort. So patient arrived at Hospital Datu at 11 p.m. and this is 4 hours after being bitten. So at Hospital Datu, his GCS dropped to 8 out of 15 and his pupil was 3 millimeters and sluggish with drooling of saliva and weakness over the neck, muscle and body. And the clinicians also noted there were few episodes of bradycardia. So as you can see the picture at the bottom left, that's how his left foot looked 4 hours post-bitten. And at 12 p.m., you can see a more clear demarcation of the thermonecrotic changes over the left foot. Okay, so for our panelists, maybe anyone would like to sort of give us an idea of what you think is so far?
Okay. First of all, thank you. I just want to say thank you to the committee for inviting me. So at this point of time, as it is difficult for us at the initial presentation of, but it is lucky for the doctors at the KK because the patient able to give a history of confirm that he got bitten by a snake. Okay, but at that point of time, he himself cannot identify the species of the snake, even though this is one of the commonest presentations of patient with snake bite, where they sometimes they cannot give the exact so-called this identification of the snake that got that involved in the in the case. So it is so broad. It is so that the patient give only a black snake, but from the history just now, they did the patient did mention that the snake has a special presentation, that it has so-called this hooding, right? Okay, and then with that a specific description from the patient itself with these kinds of so-called tissue injury. So in Malaysia, local tissue damage following snake bite is can be caused by two species. It can be caused by either cobra, especially Naja species, or pit vipers. As from the history itself, the patient's able to give you the description that the snake is actually have hood. So the possible snake that cause this kind of tissue damage is cobra, especially Naja species, where you have this local dermonecrosis in Naja species bite.
All right, thank you, Dr. Mashita. Maybe is there anyone else who would like to give your comments?
Hi.
Hi, Dr.
Hi, Emilia. Yeah. So thank you again for inviting me here. I just want to give my idea about it at this point of presentation, wherein it's a snake bite with a neurologic signs and also a venom that has a content of myotoxins because of hematoma or necrotic formation already. So in our country, we just consider two important snakes, the viper and the cobra. So if ever there is a weakness, because in our country we only have one anti-venom, which is for cobra. So if there is episode or any first sign of weakness, especially the first sign, which is ptosis or any weakness in the oropharyngeal muscles, then we will give our cobra anti-venom even if the snake is not yet identified. Thank you.
Okay, thank you, Dr. Rachel. Okay, so we'll continue. So for our impression on the case, so this is an unidentified snake bite with systemic envenoming syndrome as evidenced by presence of neurotoxicity, and patient also had relative bradycardia along with multiple episodes of vomiting. Okay. So moving on to the immediate management during that time. So in view of this snake bite poisoning, so the patient is immediately started on NKVE, which is Naja cautia antivenom, 10 ampoules with careful airway monitoring. So during that time, he was also given high flow nasal cannula as well as frequent airway suctioning. And due to his severe pain, where his pain score was 10 out of 10 during that time, he was given IV fentanyl of 100 microgram 2 times a day for pain at the pain management at the bedside. So during that time, several blood investigations were taken. So if you can see the picture on the lower left side, okay, so he looks quite drowsy, and there we can see his attention, and he was given NKVE during that time. And if you see the picture of how he appears after completion of the first antivenom injection, so he seems to be much better. He's able to play with his phone during that time as well. So several investigations were done during that time. So as we can see here, his full blood count. It showed raised white cell count. There's leukocytosis with thrombocytosis and normal hematocrit levels. So his renal profile also showed mild hypokalemia, and his liver function test generally was normal except for markedly raised ALP. And his coagulation profile was normal as well, and his blood gases showed elevated bicarb with some level of hypoxemia. And there's also elevated creatine kinase and lactate dehydrogenase. And ultrasound of the left foot was done during that time, and there was edematous areas at the left foot, which resembles cobblestone, but it did not cross the ankle joint. So maybe one of the doctors, what do you think about the case right now? Or like, how would you manage following this investigation?
Hi. Just want to ask, is the hospital available for taking any cardiac enzyme or and troponin?
Only creatine kinase was done during that time.
Only creatine kinase. Oh, because the patient is having some bradycardia, and it can be due to the snake bite if the species is Naja species, because Naja species can also cause some cardiotoxicity. So if there is some ECG changes, it is also better for us to have taking the cardiac enzyme and also the troponin if available. But of course, if the patient already shows symptoms of neurotoxicity, so there is systemic envenomation, and neurotoxicity plus cardiotoxicity is the species in Malaysia that can cause both neurotoxicity with cardiotoxicity is mainly Naja species. So we can proceed with Naja cautia antivenom, because in Sabah, this in Sabah, right? In Sabah, there is no Naja cautia, but there is only Naja sumatrana for Naja species. But the antivenom can be cross-neutralized by the NKAV. So for this case, we can start to give the NKAV for the systemic envenomation as shown with the neurotoxicity and cardiotoxicity. Thank you.
Okay. All right. So proceeding with the management of this patient. So he was reassessed after 2 hours post NKVE antivenom injection, and during that time we can see here the child appears to be well. He is stable under room air, and his hemodynamically is well. But during that time we still noted some episodes of bradycardia where his heart rate went down to 60 beats per minute. And currently his pain score is reduced from 10 out of 10 to 5 out of 10, and there was no worsening of systemic or local envenoming syndrome. And he's also able to tolerate orally well. So during that time, the child was admitted for observation in the general pediatric ward. Okay, so this is the plan that was given to the patient. So he is to continue observation under room air, and he's given crystalloid, where he's given IV half saline dextrose 5% at 33 cc per hour. And he's also covered with antibiotics with regular augmentin and also syrup paracetamol. So he's also monitored for snakebite chart 2 hourly, and if he is well, the timing becomes 4 hourly. And also there's continuous monitoring 4 hourly of creatinine kinase levels as well as full blood count. And again, during his admission, we'd like to watch out for any re-envenoming syndrome or any worsening of local envenoming syndrome. And it's also planned to reassess any necrotic tissue once the swelling subsides. And if for the dermonecrotic region, they plan to clear it. And if required, wound debridement would be done as well. So that's all for the first case. Is there any questions from the floor or any information that our panelists would like to share with us before we move on to the second case?
Hi, Emilia. I just want to ask if this patient developed blisters or bullae.
Actually, throughout his admission, based on the information that I received, he did not develop any bullae or blisters. Yeah.
I
So,
see.
yeah, he had dermonecrotic changes, but then it resolved with all the antivenom injection and also the continuous paracetamol and all conservative management was given during that time.
One thing also to add, I just want to grab this platform in order for me to share. I have a case which is the same as this one, but it also presented with bradycardia. So I think this is also important because here in our country, though there is only one and about 2 cases already that I've heard, patient bitten by cobra presented with bradycardia, but then the one hospital gave only atropine, and then there was also a resolution of bradycardia. Maybe because some of the analysis of the cobra venom their venom have also a acetylcholinesterase enzyme. That's why they consume rapidly the acetylcholine neurotransmitter. Maybe that's one factor also. Some of the snakebite patient, aside from neurotoxicity signs and symptoms, you have also this cardio complications also, aside from the 3-fingered protein, which is a cardiotoxic. But I think also there is also importance on the acetylcholinesterase. So yeah, because that hospital just gave atropine, and then the bradycardia resolved, and then a little improvement of the motor strength. No neostigmine, it's only atropine because there's no neostigmine in the hospital. So they stopped because when you give neostigmine in a cobra bite patients presenting with weakness, you gave the atropine plus neostigmine. But since they have no neostigmine, they only have atropine. So they pre-treat patient with atropine, and then it gave a improvement of bradycardia, and then weakness also. The weakness improved, but not totally reversed. So that's all I can share. Thank you.
That's interesting. Thank you so much, Dr. Rachel. Actually, I have not encountered a case where atropine was given in patients with bradycardia. And yeah, that's thank you for the information. All right, is there anyone else who would like to add? Or I can move
Maybe
on.
Dr. Chu would like to comment about the bradycardia with atropine in early envenoming, cardiotoxic.
Okay. Because of the snakes contain the toxins, they can be mainly is a neurotoxin, and for cobra toxin, and also they also have a cardiotoxin, but now they change the name more to cytotoxin because mainly it's the myotoxic effect, but they still can have manifest as cardiotoxic envenomation, and in some cases not common, but in rare cases that sometimes the cardiotoxicity may happen even before the neurotoxicity envenomation manifests. So when the patient arrive to the hospital, even if the patient having just some local symptoms, especially if we are unsure the species, or even if we know the species, like the patient can describe the snake is black color, has a foot and able to rear out, we must keep in mind that we need to at least do a ECG, and it's better still if we can provide the continuous cardiac monitor, because any ECG changes, it can be attributed to the cobra toxin. So especially in young patients, that there are no risk factor for any heart diseases, like a young patient without any congenital heart disease, or there is no underlying comorbid, then any ECG changes, it can happen as such. And there is also a case report published by Prof. Khaldun that the patient can even have ventricular biseminy, and which resolve at last just by one valve of the NKAV. So, but today there is no guideline to administer antivenom solely for cardiotoxic envenomation only, because so the dose of antivenom for cardiotoxicity is unsure. But for neurotoxicity, we know that in the guideline is 10 vials of NKAV. So in the cases that they have a cardiotoxicity manifestation, we have to monitor closely for neurotoxicity. Once the neurotoxicity symptoms appear, then we can pick up early and give the antivenom early, as per the guideline. Thank you.
And that's a very important point, where sometimes, as Dr. Chu said, early symptoms of cardiac manifestation may appear before any systemic envenoming for, say, for example, muscle paralysis. So if you don't monitor, or if the patient don't come to hospital early and you don't monitor, you will miss that. But there's another important point, as Dr. Chu said. It can be, it's actually a sign of systemic envenoming already, right? So in one of the case that Dr. Chu going to publish is, proceed to become muscle paralysis. For example, the earliest sign is ptosis. So that's the sign that we give already antivenom. But if you have a cardiac signs already, I think rather than waiting for ptosis to appear, we can already start the antivenom. Use the full dose, because it's also what we call systemic envenoming. So that is what we've learned from the cases we've managed. Okay, right. So from the Dr. Ruchel mentioning about using atropine and no anticholinesterase inhibitors. Yeah, I mean you can, but that's a treatment symptomatic just for the bradycardia. But the other problem that I think more dangerous is for the muscle paralysis, postsynaptic postsynaptic what do you call envenomation, blockade. And yes, anticholinesterase inhibitors can be used to transiently so-called compete, but it's not neutralizing the venom. You have to understand that, very important. Once the half-life is gone, then the venom, if the venom still there, it can just go and block again. So it serves as to sort of like knock off the venom from the binding site. But if you don't mop up the venom in the circulation, then you will still continue having the risk of binding again, right? So that's why anticholinesterase inhibitors may not be the only solution for solving neuromuscular envenoming like this. So it has to be used in conjunction with the appropriate antivenom for the venom of the species. Okay, right. So I think in Philippines we have maybe one or probably two now of the antivenom. We'll see how it goes. Hopefully things will improve in the next couple of years. Okay.
Thank you,
Right.
Dr. Khaldun.
Yeah. It's important to understand the concept. Some people say, oh, we just use anticholinesterase inhibitors, that's fine. But you have to know what is the function, how it works, and how it actually, the venom itself is not going to be neutralized. So the word neutralize with anticholinergics inhibitor is inappropriate. Yeah.
Agree,
Okay.
agree.
Yeah. Okay. Very good. I think we have questions. Do we have questions?
Yes, Prof. So we have questions from several people. So I'll start with the first one. This question is from Nabil. So what are the key features that healthcare providers should look for identifying the type of snake bites based on patient's description?
I personally think that it is actually quite difficult to just based on patient words
Yeah.
for us to know which species of snake. So that's why we have actually one guide, the land snake of significance in Malaysia. So we can use the image insight to ask the patient to see which one is the most likelihood. But of course, it's not 100%. Even though the patient point to the snake that he think it is, but we still cannot take for granted that that will be the culprit. We still need to rule out others. So we still will proceed with all the snake bite charting, still the serial blood investigation. That is just for a rough guide only. It's not for 100% confirmation. This is my opinion. Thank you.
Yeah. Tomashita?
I do agree with Dr. Chu just now. It's very so-called, I did mention just now, it's easier for us to actually treat the patient if patient able to tell you, or patient able to bring you the snake to the hospital. It will actually facilitate us in making diagnosis, in making as a guidance for us to either the patient should be on antivenom or not. It is very difficult if only if the patient description is sometimes it doesn't tell you the clinical presentation at that point of time. So it is, as Dr. Chu said just now, if the patient able to bring you the snake is easier, or the patient able to take the picture of the snake before they come to us, or actually they can go through this gallery of snake importance in Malaysia to actually give to us an idea. And so and also the geographical of the incident also can actually guide us in not to say guessing, in guiding us the type of snake that involved in that particular presentation.
Okay, thank you, Dr. Nashita. Okay, so I'll move on to the next question. So this question is by Wan Muhammad Arif. So what are the guidelines for anti-venom administration in case of neurotoxic snake bites, and what are the potential benefit and risk? Does anyone would like to share your opinion on this?
Dr. Rocha?
Yeah. Hello. Sorry.
Yes.
In our country, we have a guideline, but then since we have a issue on supply, even if the guideline would say 10 to 20 ampules in severe envenomation, in my practice, even if the patient is intubated, I will just give only 3 to 5 ampules, even if the guideline would say 10 to 15 ampules. It's because the stock would matter. And then because I have a lot of experience wherein even if under dose, I'm not following the 10 to 15 ampules, but then the paralysis would be reversed in 3 to 5 ampules already. Then the additional acetylcholinesterase. But if you have a lot of stocks, then you can follow the guidelines because that is really what is studied upon. So it would really depend on the stock. Mostly in my own experience, the paralysis will be reversed at 3 to 5 ampules, even in severe poisoning. If not reversed, then I will give, because the guideline would say if the first dose, the symptoms will not be reversed in first dose, you must double the dose in the next administration of anti-venom. But then it would depend on the stock. So for me, 3 to 5 ampules would really reverse the symptoms, the paralysis or the neurotoxic symptoms. Thank you.
Okay, so that's from the Philippine guideline. I think that double the dose for the second one, it's a bit an overkill. It doesn't make any sense. So it can just repeat with the either half of the dose or full dose of the first dose if you want to repeat. So double the dose for a top-up dose is a bit unusual. I don't see any the basis for that, as you said. So anyway, what about Malaysian guideline in giving the antivenom, Chu or Mashita?
For Malaysia, we are actually following the guideline that is also inside the same guide, the length neck of medical significance in Malaysia, 3rd edition. Over the last few pages, I couldn't remember the exact page number, but the last few pages there is a there is a list of the snake, the venomous snake, and also the antivenom manufacturer, and with the first dose and the vials and the subsequent dose that we can give. So we will mainly follow that guideline. So for the Naja species, for systemic envenomation, we are giving 10 vials of the NKAV, the cobra antivenom, and for king cobra is also for systemic envenomation also is 10 vials. The subsequent dose is also 10 vials after 1 to 2 hours. 1 to 2 hours after the first dose. Then for others like pig viper, we will start with 3 vials first. And for crate, it's 5 vials each, but the crate antivenom depends on the hospital. Not all the hospital keep the Malayan crate antivenom and also the better crate antivenom. But the doses we follow the guideline is 5 vials and the subsequent dose also is 5 vials. So we are mainly following the guideline for Malaysia in managing both the neurotoxic snake bite and hematotoxic snake bite.
Yeah, so there is what you mean is there is a local envenoming and there's a systemic envenoming, right?
Yeah.
There's a slightly different dose for the neurotoxic snakes.
Yeah.
But for the pit vipers, I think it's all the same, whether systemic or local. Okay, all right. So any more questions?
Yes. Okay, there's 2 more questions. There's 3 more questions actually. So okay, the first question is by Roy Aaron. So he would like to ask what additional precautions could have been taken during the transfer to Hospital Lahad Datu to monitor the patient's condition, especially considering the worsening symptoms during the journey.
Okay. So as we all know from the history, physical examination at the KK itself, patient is having neurotoxic envenomations. So as from the KK itself stated that the patient still able to maintain the airway. As you all know, in neurotoxic envenomation, death may result from aspiration, airway obstruction, okay, or respiratory failure. So apart from continuous monitoring of the bradycardia itself, the most important is you have to make sure the clear airway must be maintained. Okay, once I think the transport team is crucial of transporting this patient, especially in pediatric patient from so-called one center to the tertiary center. Okay, so the team should be well equipped with all these resuscitation equipment, and you might not want to have an unlucky day to intubate patient in the ambulance. So the airway should be assessed, should be maintained before you transport out, especially now neurotoxic envenomation patient to the tertiary center. Currently most of the district hospital is having is been stored by antivenom. So we don't really have so-called this problem in initiating antivenom at the district level itself. But it is difficult if the patient goes to the clinic kesihatan while there's no antivenom being stored in clinic kesihatan. So the transporter, including the MOs, should have a so-called knowledge, should have a skill in resuscitating, especially pediatrics age group patients, while transporting patient to the tertiary center. Okay, as simple as if the patient goes into respiratory collapse, as simple as putting in a laryngeal mask airway, or give a positive pressure ventilation to the patient throughout the journey to the tertiary center.
Okay, so that's very important. The most important is the patient cannot be transported alone. A doctor must be available with the patient throughout the transportation, monitoring continuously, especially for the vital signs and also cardiac signs, and also the respiratory effort. So if patient needs intubation, you have to stop and intubate, ventilate, and then move on. So that's very so-called important. For example, if let's say Dr. Mashita said all district hospital now have antivenom, but sometimes the antivenom they have is not the monospecific antivenom. They may have a polyspecific antivenom. In this case, a polyneuro antivenom. They can and if let's say if only 2 valves they have, so they can start the antivenom while waiting for the other units of the valves to arrive from the other hospitals. So we are, rather than transporting the patient to a tertiary hospital, we transport antivenom to the patient in the district hospital. Okay, so that is actually helping the patient not to going to be too far away from the family. At the same time, will be safer in avoiding this issue of transporting patient collapse during transportation. So transferring the AV will be a safer option compared to transferring patient. Okay. Right. But if patient is from KK, Klinik Kesihatan, then that's going to be difficult because, even in KK, if they can intubate, that will be good as well, right? And we'll get the antivenom when they arrive to the district hospital. KK is a clinic, a community-based clinic, right? So they are very limited. May not have doctors, but some clinics have doctors. All right. Anybody would like to add on to this, Chu? Or in terms of Sarawak situation, you're based in Sarawak, also quite difficult.
Yeah, so far, because the district hospital, most of the time they don't have enough oxygen point. So my experience previously is they will intubate the patient and send the patient to the tertiary hospital. Then we will stand by the antivenom there and give when the patient arrive, if the patient need the one. So so far I have no experience in sending the antivenom to the district hospital yet, but that will shorten the time to antivenom actually, but it depends. It involves the PHC part, so sometimes it's quite difficult because the district hospital has ambulance, so they need more. There are a lot of paperwork and process that they need to discuss. So by the time that they reach because we have a case, it's not related to SNAC, but it's related to heavy metal poisoning. So the discussion about sending the antidote and sending the patient takes almost 1 day. So might as well just ask the patient, you just ask them to just transfer the patient here. So sometimes it's not because of the stock problem, it's sometimes because of the process, the procedure to get it done. So that is the limitation. Yeah. Okay.
Yeah. Okay. Ruchel, do you want to add on a bit more? No. As the situation I know is very dire in terms of transport in the Philippines.
I agree to. Yeah. But in our toxicology center, it's our campaign because we really have a lack of supplies of anti-venom. So that's why we want to buy time that the patient will not proceed into respiratory paralysis. That's why we distribute atropine neostigmine just to buy time, and the patient will be transported to a higher center where there is an anti-venom. But in a case wherein there is already imminent signs of respiratory paralysis during transport, the ambulance should drop the patient to a nearby hospital for the intubation. Remember, I always experience that if there is a good intubation and a good respiratory support, the patient will always the paralysis will always be reversed if no ischemic encephalopathy that happened to the patient. If the antivenom is will be given, so the paralysis and also the comatose state is just a temporary if there is a antivenom available.
Yeah, so that's I'm at the 10th World Congress on Hepatology here in Kuching, and we had a very interesting presentation from Indonesia, and they're already thinking of using drones to transfer antivenom, you know. So it seems to be a viable alternative in the near future if you want to think about it as an alternative rather than sending the ambulance. We can send drones, or if somewhere in the maybe not too far away, we can probably go and use Grab, you know, public transporter. So why not? So this is some of the sort of like innovative thinking that we want in order for us to use whatever necessary current method of maybe transport. Rather than patient transport, we transfer antivenom and maybe using drones in the future, in the near future, will be really a viable option. People are already sending delivery of DHL and so on using drones, so why not we use it for antivenom? Yeah, it's very interesting. Maybe something we should be thinking of in the near future. Okay, any other question, or can we move on to the next question, next case?
Prof, there's two more questions.
Okay.
Okay. So another question is from Zinjie. So we'd like to ask whether is it a correct or advisable practice to use a tourniquet to confine venom to the affected extremity, especially in emergency situations where healthcare services are not readily accessible.
Maybe Ruchel, you want to respond first?
Yeah. Tourniquet is discouraged in any bite, but there is a what do you call this one? Initial intervention wherein immobilization and compression bandage just to delay the distribution of venom, especially if the bitten area is in the extremities. So you can immobilize and then avoid contraction of muscles. Then there is delaying compression bandage, elastic bandage, or any cloth that can compress the lymphatic vessels. Then just to delay the distribution of the venom, but it is only advisable in neurotoxic envenomation and not in vipers. Mostly it is advised in cobra, wherein delaying compression bandage can be temporarily placed on the bite site or on the whole extremity.
Thank you, Dr. Richard. So I'll move on to the last question for this first case. Okay, so this by San Young Chan. Do you want to ask regarding cardiac enzymes or troponin I, as what mentioned by Dr. Chiu, that is raised in this patient, does dual antiplatelet or anticoagulant have a role in this kind of situations?
The pathophysiology is different. So far, I don't think there's any role for antiplatelet anticoagulation in this type of situation.
Yeah. The one that is issued, you should be giving antivenom, not the antiplatelet.
Yeah.
So
antivenom is
pathophysiology is different completely. Yeah.
Yeah.
Right. Okay. Right. So we move on to the next one.
Yeah. So that's our first case. Thank you. So we'll move on to the next case.
Okay, so moving on to case number 2. Okay, so this is a 39-year-old man with no known underlying medical illness who worked as a farmer. He alleged multiple hornet stings over trunk, back, neck, head at 4 p.m. because he was trying to burn the hive of the hornets on the tree, and subsequently he was chased by the hornet and sustained the hornet stings. So after that, at 6 p.m., he experienced worsening of left-sided chest pain, which was freaking in nature, with pain score of 8/10 and relief by sitting up and leaning forward. The pain was also associated with epigastric discomfort, water brush sensations, nausea, diaphoresis, and shortness of breath. However, there was no palpitation, no dizziness, no fever or breathing tendency. He was admitted to Hospital Tambunan for 2 days with supportive management. However, he was then referred to Hospital Keningau in view of his worsening biochemical parameters, suspecting of rhabdomyolysis, transaminitis, and coagulopathy. So upon his arrival at the ED of Hospital Keningau, he was alert, not tachynic, with good pulse volume, and have warm peripheries with capillary refill times less than 2 seconds, which was normal. His vital signs shows slightly hypertensive and otherwise all normal vital signs. And he has bilateral periorbital edema and has multiple hornet stings marks, which was total of 160 stings, as we can see on the photos on the right side of the slide. The hornet stings were over his scalp, his forehead, his neck, anterior chest, his back, but there was no urticaria rash. Otherwise, the other systemic examination was unremarkable. So moving on to the investigations, his full blood count showed raised white cell count with very low platelet at 15 and slightly reduced hematocrit level. His renal profile was deranged with hyponatremia, hypokalemia, and raised urea creatinine. His liver function test was also deranged with mildly raised ALT and AST. And coagulation profile showed prolonged PT and APTT. And his creatine kinase also raised at 15,800 something. ECG was done and showed sinus rhythm with T inversions at lead V4 to V6, but there was no any other dynamic changes. Echocardiogram was also done and showed there is ejection fractions at 45 to 50%, and there is borderline low atrial volume, mild left ventricular hypertrophy, no right ventricular hypertrophy, and there is hypokinesia at the basal mid anterior septum, mid inferior septum, and anterior apex, with no pericardial effusions. So subsequently, the patient was admitted to ICU for close monitoring, and some of the medications are given, including intravenous hydrocortisone, intravenous pantoprazole, intravenous vitamin K, intravenous ceftriaxone, and also oral pyritons, and also lactic courtiers for hyperkalemia. He was later also on several times of hemodialysis, and after that, the patient's condition subsequently improved and he was discharged well. So we would like to invite our panelists to give some comments on the case presentations earlier.
Okay, so me myself don't have much experience of severe hornet sting cases that cause severe rhabdomyolysis as been discussed in this case. But most cases that I counted are mild, but some present with anaphylaxis, because in so-called this hornet sting toxicities on human largely due to the effect of venom. Venom induced a type 1 hypersensitivity. So in this case, patient have so-called multiple organ involvement that actually due to, for example, rhabdomyolysis. It can be due to possibly related to a direct toxic action from the venom itself, and it goes to others, for example, transaminitis and coagulopathy. So the patient should be monitored closely as this patient has been transferred to ICU for close monitoring, and I think that the hemodialysis is actually basically is not due for the venom clearance of the patient, but it is due to the complication of the patients of getting this acute renal failure following the envenomation.
Right. Okay. Can we see the second page? Ruchel, you want to comment?
Uh,
Do you have more
though
this type of
in
incident
my
in the
clinical
Philippines?
in my clinical practice, though mostly if there is a Hymenoptera incident, we always blame the bees. So it's all already generalized as bee sting, but then um, some of the people cannot recognize bees from wasp from hornets. But here it's a hornet case, wherein there, even if in one hornet can sting several times, but in my experience, I have I have more experience on the bees, because the stinger is left when during the incident. But here, if there is no stinger left in the patient's body, so it might be really a hornet, and if the patient really identified it as a hornet. So as uh, what is written in the books about Hymenoptera, it always contains histamine and the peptides and then the kinins, and also some sort of phospholipase A2, and then metalloproteinases that will destroy muscles also. So we all do the supportive management, but we must watch out really for just like this, the complication or the sequelae of several things is rhabdomyolysis. So here we can be aggressive on the management of the rhabdomyolysis, and also supportive management like antibiotic and then the tetanus prophylaxis.
Right. Okay, Chu, you want to have a go at this case? Can we see the next slide?
Um, the blood investigation was how many hours after the incident? May I know the timeline?
So patient arrived to hospital, I
Yeah,
think,
it
how
was
many
taken at the
minutes?
hospital clinic now, so it's 2 days after the incident.
2 days after, okay. Because
Yeah.
usually the CK level won't be so elevated within the first few hours. The CK level
Yeah.
usually slowly climb out. So that is the
Yeah.
reason why even initially the CK level is not high, but because of the incident of more than 100 stings, we need to monitor very closely for the urine output and start the hydration and serial CK level, maybe 4 to 6 hourly, but it depends on the situation because the CK level usually won't elevate so fast. So in this case, 50,000, so it's 2 days later. So I think with the hyperkalemia and the urea creatinine as such, most probably the patient is having oliguria or even anuria. So I guess that is the reason why the patient went for hemodialysis because there is no other way to wash out the myoglobin urea. So to treat the rhabdomyolysis. So that is the only way to treat the rhabdomyolysis. And another blood test that is of note is the platelet count is very low. So there are cases that severe anaphylaxis or can associate with thrombocytopenia. I also read through some case reports showing hornet sting or bee sting because of the very severe reaction towards the histamine release and mast cell progress as well. So result in thrombocytopenia. But I never see so low until 15. So maybe there are some other reactive reaction at the same time as well. But I have never seen so low.
Yeah.
So maybe maybe Prof can enlighten us
Yeah.
a bit on this.
Yeah, so I mean, this is that's why this case is very interesting because it shows all the all the issues with systemic envenoming from hornet sting. We only sometimes read about it, but we never seen it. So in this case, Maybe because the patient presented a bit late, everything is already starting to manifest. All the damage has been done, and that's the reason why we immediately put patient onto dialysis. We had previous cases in other states where patient was put on dialysis a bit late on day 5. So this one on day 2 already we already giving. We think that that will actually help the patient, and it proven that that helps as well. Can you move to the next slide? So I'm not sure what is the CK because we do serial CK. I'm not sure what is the CK after the dialysis. I'm sure you can have a look again at the case report, the case file. But those things will be because we don't have antivenom for Hornet, so we treat symptomatically. So if the patient have problems with acute kidney injury, we treat it that way. If patient has rhabdomyolysis, we treat it with flushing it out and by dialysis. So hoping that all the effect from the venom will stop uh, 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 before we while we are actually doing the therapy. So it's a matter of maybe the half-life of the venom is not as long, hoping that I mean the net production of all this material that can be detrimental to the kidney will be reversed with the intervention that we do. So I'm not sure here if you notice it's a vitamin K giving. Is there any role for vitamin K for this patient? Mashita, maybe? Why giving antivenom vitamin K? I think that may reflect the coagulopathy or low in platelet count that the patient have.
Yeah, I think so. I'm not
What's
sure.
the INR level? INR count? Yeah, Mashita.
The INR is prolonged. The INR maybe because of this, they are thinking more of this coagulopathy but I don't think I'm not sure either in Hornstein vitamin K is recommended in managing all this so-called this coagulopathy and all these things, Prof. I'm not sure.
Yeah, okay. Maybe Ruchel, what do you think? You give vitamin C for patient with envenoming causing INR to be low, to be raised and low platelet?
Yeah. Vitamin K, I also use vitamin K. It's also discussed in our books. If there is a altered pro time and external coagulation, the ranged factors. So usually I also use this in a Viper bite wherein there is an elevation of INR, and then if there is no bleeding, I just used vitamin K, and if there is spontaneous bleeding with the Viper bite, and then I will use FFP and blood transfusion if there is already anemia. So because we have no an anti-venom for the vipers. So here, I think that the vitamin K is used for the prolonged pro time.
Yeah, but we need to know what vitamin K does, right? So maybe Chu, you want to respond to this? Why vitamin K? Do we use vitamin K for such envenomation?
Actually, Prof, I've never seen people use vitamin K for honesty, but just came through some case report that if the patient with severe honesty and end up with rhabdomyolysis with multi-organ failure, especially like this case, there is liver failure. I think with coagulopathy, there are some case report that they use vitamin K to handle just for a bridging therapy. And plus this case, they are going for hemodialysis. So I think they are worried that during the procedure, they might have a lot of, they're worried about the bleeding. So they are giving this. I'm not too sure about it, but that is my guess because the patient has quite severe transaminitis with a deranged INR. So to carry out the procedure, I think they want to correct the coagulopathy and while carry out the invasive procedure.
Yeah, so what does vitamin K do?
Oh, vitamin K. Actually, vitamin K is only for the synthesis of four coagulation factor, the 2, 7, 9, 10. So if the patient um is having coagulopathy due to liver failure, theoretically all the coagulation factors are affected. So
Yes,
so most likely FFP will be a better choice. So in those case report or case series that I go through before, they just put as a statement, they say either vitamin K or FFP were administered for the coagulability, but they never mentioned, and I couldn't find any articles that they compare these two. But theoretically wise, for liver failure with coagulopathy, vitamin K won't help much because it's only
ex-
a seed for the four factors. FFP is the one
exactly.
that can replace all the coagulation factors.
Exactly. So blood
Uh,
transfusion most likely will be better
yeah.
than
And if
giving a vitamin K.
the
It has a you have to
addition
understand what
comes,
vitamin K does, right? You have to understand what vitamin K does.
yeah.
So, for example, in snakebite envenoming, also for the pit viper, but people give vitamin K when they understand what the venom does. In pit viper envenoming, the liver is not affected so much, but the issue is the number of factors in the circulation, right? That's kind of coagulopathy, leading to coagulopathy is the circulation issue. So the liver is still producing the factors. Giving a vitamin K will not really increase the known, the factors in the circulation. We just let the liver do its job. What we want is actually stop the action of or clear the venom in the circulation to allow the liver factors production to come up, and that takes between 3 to 9 hours. So that explains why we repeat blood tests, do serially every 6 hours. So we want to allow the liver to actually compensate the reduction of factors in the circulation when we had the systemic envenomation. So once we corrected it with the antivenom, the net production will actually improve the factor count in the circulation. So vitamin K itself will not be actually of any benefit per se. Yeah, so it's different if let's say you want to how you treat a patient with what we call this uh, can't remember what is the
Overforinization? No.
overwarfarin. Yeah, so somebody with warfarinization. So that's a different altogether because warfarin is affecting the liver. So, so this is just to replenish back the factors in the liver itself. The factory is affected, right? Am I correct? So that's why when we want to give something, we have to think of what it does. So very important. Otherwise, we'll look like we don't know what we are doing. So yeah. Anyway, this patient survived, I think. How many days was the patient on the dialysis, and also when was he discharged? Do you know?
Sorry, Prof, I did not have any info on that, but he underwent a few cycles of the
Yeah.
hemodialysis
Mm.
and was monitored in the ICU for a few days.
And I think most likely the acute kidney injury was reversed as well. That's why, and he has a follow-up. Okay, this case was in Sabah. The reason why he got stung is also very interesting. He was collecting the um, uh, hornet for the larvae to be eaten. That is wow. Yeah, we don't see it every day, but he's from Sabah, and maybe that's a traditional way of getting extra protein, maybe in the diet. Yeah. Okay. So, do we have any questions from the public, from the
Yes, Prof. We do have
okay.
two questions from the floor, but the first questions, it was answered by Dr. Mashrita just now, which is the indication for hemodialysis. And for the second questions is regarding any ECG is available. Look like these patients undergo Connie syndrome. So if there is any ST elevation noted in the ECG. So unfortunately, we don't have the ECG of the patients, but Maybe you can have the panelists to tell us more about the Cornish syndrome.
Sorry, what syndrome again? Sorry.
Cornish.
Cornish syndrome.
Yeah, anybody? Chu?
To say it is the Cornish syndrome is just purely is anaphylaxis associated with ACS type of chest pain. So the other
Yes.
name of Cornish syndrome is allergic angina. But in this case, the patient is having rhabdomyolysis in hyperkalemia.
Yeah.
So ECG changes can be due to hyperkalemia and all the multi-organ failure. So it is difficult for us to say that this can be Cornish syndrome. And for me, I will say it's unlikely because there are other causes. Okay.
Yeah, so it's a, I mean, it's a quite obvious cause. So we treat the most obvious cause first, right? In this case, it's the environment. Okay, Rochelle, you want to add on about this Cornish syndrome? Have you seen one in any of the patient?
I have not seen any Cornish syndrome, but yeah, I agree with Dr. Chu. It's a form of anaphylaxis.
Yeah. Okay. So I think the issue with Cornish, is it because of the vasospasm, or is it collection of the immunoglobulin complex from the anaphylaxis? Chu?
It is actually a combination of the mechanisms. Mainly is still related to the histamine release and the mast cell degranulation of those type. And some also they are associated with, because together with the hypotension or the cardiac effect. So I have actually me and my MO, we have one oral presentation many years ago. More than around 8-9 years ago, we went to, I think it's AMAS or something. Then we have a case of Cornish syndrome, but the patient did have ST elevation. In the end, the medical still want to send the patient to the cardiologist for assessment, and the cardiologist actually did the angiogram, because to label it as Cornish syndrome, we must have a coronary angiogram to say that there is actually no the coronary artery is clear of any stenosis. So until towards that part, then only we can say it's Cornish syndrome. So before that, we still have to rule out other causes, or put just the most possible. If we still want to put Cornish syndrome as diagnosis, it's just a differential or just possible. We cannot really diagnose it. And the mechanism, pathophysio, is a combination of all the.
Am I right?
Yeah. Yes. So that's it.
Okay.
Thank you.
Okay, so can we move on to the next case? We have time for another case.
This is a 69-year-old Malay female with underlying hypertension, diabetes mellitus, and dyslipidemia who left her right thumb at 12 p.m. So during that time, the patient was cutting lemongrass in front of her yard when a spider suddenly appeared and bit her right thumb once. So the spider was described as grayish, black, big spider with thick legs, with its body size about 1/3 of an index finger, and that's about 2 centimeters in length. So also for the spider, the image of the spider, it's similar to as shown in the picture on your left. So this is a picture of Selenor cosminae species, and the patient claimed that the spider that bit her had similar appearance to the one in this picture. So next. So following the bite, the patient massaged the area with minyak gamat, which is a QC cucumber oil, and subsequently sought treatment in KK's bowel. So in the KK, so as HPC was 17.5 with elevated glucose levels, and her urine ketone was 1+. And during that period of time, her pain score was 4 out of 10. And she was given intramuscular anti-tetanus toxoid, 0.5 mils, and subcutaneous Actrapid 8 units. So subsequently, she was referred to Hospital Bentuk for further assessment of the spider bite and uncontrolled diabetes mellitus. So upon arrival to ED Hospital Betong, so her GCR 15, and she was alert, not tachypneic, with blood pressure slightly on the higher side, isolated hypertension. And there's pulse rate is 83 beats per minute, which is normal, with respiratory rate of 18 breaths per minute, which is normal as well. So she was afebrile with temperature at 36.9 degrees Celsius, and oxygen saturation is 97% under room air. So HPC reduced to 14.4 and a serum ketone is 0.1. So lung examination is clear with equal air entry bilaterally, and cardiovascular examination showed dual rhythm normal. So on closer examination of her right hand, so as you can see in the picture on the right, there is her right hand is swollen with no obvious visible open wounds. So there's no dermal necrosis seen, and in view of the swelling, there's restriction of movement in all 5 fingers. And palpation over the right hand showed mild tenderness. Look of the right thumb. There's 2 erythematous spots seen above the interphalangeal joint over the right thumb, and again, there's no dermal necrosis seen. So next. Okay, so for our impression, this is an unidentified spider bite. Okay, so for the investigations done, the full blood count it appears normal. Both all parameters were normal, including coagulation profile as well as creatinine kinase was 61. Okay, so for the management of this patient, since she's hemodynamically stable, at a point of time she was admitted to general ward for monitoring for at least 20 hours, and they aim to discharge her once her pain and swelling is reduced and optimize the blood levels. So during that period of time, medication that was prescribed to her was double paracetamol. Okay, so after a few days, the condition actually improved. As you can see in the picture on the right, her swelling in the right hand has reduced tremendously with no dermal necrosis seen, and sensation was intact as well. So patient was discharged well. So yeah, this is pretty much the case of regarding this unidentified spider bite. So maybe and any panelists would like to give your thoughts on this presentation?
Dr. Chu, we have a case at the moment.
Yeah, we have a case of it is a tarantula bite.
Yes.
At the moment. For this case, we didn't know the species, but for the spider in Malaysia, most of them has the poisonous fangs, but serious medical attention is not routinely needed. But of course, we still need to watch out for those serious things. Like, for example, in tarantula, because their bites are associated with the urticating hair, the hair itself, the bulbs of the hair can cause some histamine release. So in patient that is prone to allergic or asthmatics, they might even trigger bronchospasms and urticaria on the body. And tarantula bites can cause deep throbbing pain and swelling also. The most serious part is they can cause necrosis, but in this case, there is no necrosis of the skin. There is no dermal necrosis. So mainly for it is supportive treatment with with the analgesic and monitoring. There are no antivenom needed for all the spiders in Malaysia. That is what I know about it. So maybe someone else can add on. Thank you.
Dr. Machita, would you like to give some thoughts on this case?
Yeah, okay. Again, I had a limited
in my end, sorry.
in managing this spider bites. Okay, so as Dr. Chu just said just now, most spider species, so in Malaysia is considered harmless, even though it is venomous, but I believe it is not dangerous to human being, to us, to human. So it is a spider bite. I think it is rarely reported, partly because due to the mild effects from the bite. So patient do not seek medical treatment in the hospital. So patient don't come to us because of this mild effect. So as in these patients, what we can do is As you all know, most of the hospital in Malaysia do have this access block. Most of the patient, especially medical patient, do stranded being lodged in emergency department. In these patients, because of the local effects of following the sting, patient might not be. It's not necessary for patient to get admitted for example, in my hospital, the patient will be in our observation bay for continuous for observation of this swelling itself, because as I did mention just now, it is even though it is venomous, but I believe it is non-dangerous. So what we can do is reassurance to the patients, and then the pain relief, and wound management, the ATT. Okay.
Thank you, Dr. Mashita. How about Dr. Richel? Do you have any similar experience managing these kind of patients in Philippines?
For me, I never experienced any severe envenomation with regards to spiders, but yeah, I agree with the supportive management only. I just want really to if I discharge patient, I really closely follow up patient if there will be symptoms during discharge. Remember that the black widow spider, there is a what do you call this one, an event like webbing, like the eggs of the spider from Australia will be on air and traveling as a web with the eggs. Then it might we have a reported case here in the Philippines that the black widow spider is here already, because they theorized that it is from the web and it is flown by air. Then it is locally present in the Philippines, the black widow spider, wherein there is a latrotoxin and it will cause neurotoxic envenoming. But so far, no case like a severe case of spider envenomation.
All right, thank you, Dr. Richel. Maybe Prof, would you like to give any thoughts on the spider bite case?
No, I think it's as Dr. Chu said, it's more syndromic approach, symptomatic approach. So yeah, that's a bit.
All right, thank you so much, Prof. So we'll move on to the next case. Oh, sorry. Prior to that, there is some questions from the floor. Okay, so our first question is by Nur Amira. So it's regarding if there's any red flag symptoms to watch out for spider bite cases. So maybe anyone would like to answer?
What's the question again?
If there's any red flag symptoms to watch out in case of spider bite.
For me, the red flags will be the neurotoxic, like the brown recluse spider, wherein it really caused necrosis on the bite site, and it will be it will progress to area where the site is beaten. So there is brown recluse spider for necrosis, and then the black widow spider for the neurotoxic envenomation. So that would be the red flags if there is signs of weakness and also myonecrosis.
Maybe anyone else would like to give their opinion as well for any red flag symptoms for the community to watch out for?
So in Malaysia, we have brown widow. We have a few cases. Again, the sign symptoms is limited, so we treat symptomatically for that cases. Brown widow. Have a look in the literature for those in Malaysia. Yeah.
All right. So for our next question, it's from Daniel Jaslina. So is there any difference in management amongst the various types of spiders? So maybe Dr. Chu, would you like to answer this question?
If we are talking about those Malaysia spiders, they are not much different because mainly are all supportive. We don't have spider bite that can result in very severe envenomation like neurotoxic envenomation in Malaysia. But sometimes we might get spider that are being imported either by accident or they smuggle it to sell it as pet to Malaysia. Then we might get different species from other countries which is more venomous and those management might differ. But just for Malaysia bite, like let's say you have a patient from come to you bitten at home or bitten in the wild, like in the forest or etc. There are not much difference in the management. Mainly it's just supportive. It's just that like even for the brown widow also it is much less harmful compared to their cousin black widow. So not much difference for Malaysia spider. Just worry about those being imported from other country. That's it. Thank you.
Dr. Chu, how about Dr. Ruchel? Is there any difference in management amongst the different species?
I agree with Dr. Chu also. It's and Dr. Kadu Ismail. It's a supportive management, but in the brown recluse spider, it will really cause pain. So you might climb up to a opioid treatment for the pain, and some will manifest with spasm. So you might add management on the calcium because there are some that will manifest for spasm. So and the ionized calcium is low. So yeah, it depends on the laboratory result. But yeah, the significant management is how to control pain. So if NSAIDs will not work, then you might climb up to opioids, like giving fentanyl or morphine.
All right, thank you. And the next question would be, it's from Arisha Omaira. So is it possible for spider bites to be managed conservatively at home? So Dr. Matuka, would you like to take this question?
As I did mention just now, Malaysian spiders is actually venomous, but it doesn't cause so-called it doesn't cause, it is not really harmful to the human being. And because of this local a few so-called this local effect, this mild effect that leads patient most of the time they just stay at home, and as been as you asked just now, if that is only a mild effect, you can actually observe, you actually you don't have to come to the hospital unless that is so-called you are concerned of getting envenomation from, for example, as Dr. Chu said just now, if there is any imported spiders from outside. But because most of the spiders in Malaysia is actually not harmful, even though it is venomous. Okay.
All right, thank you so much. Okay, so with that, I think we can move on to the next case.
Okay, so moving on to the case 4. This is a 21 years old Malay lady with no known medical illness, presented with sudden onset of outer conscious level after eating mushroom, in which they call it kulat pusu kambing, picked by her father at a rubber estate. The mushroom was cooked in the soup, and the soup was taken at 3 p.m., but the symptoms occur at 6 p.m. It was associated with dizziness, lethargy, and 2 times of vomiting with mainly fluid content and no blood. The father and also the elder brother had complaints of the dizziness and vomiting as well, but there is no outer conscious level. Otherwise, there was no fever, no upper respiratory tract or urinary tract infection symptoms, no abdominal pain, no chest pain, no palpitation or shortness of breath, no headache. The patient claimed that she had history of taking similar food before, but it was asymptomatic. So upon her arrival at ED, her GCS was E4, V1, and 5, which was 9/15, because the patients appeared confused and refused to talk. And however, she was not tachynic. The capillary refill time was normal. She has good pulse volume, warm peripheries. The pupil was 3/3, reactive to light. And she had occasional vertical nystagmus bilaterally. The vital signs were all normal, and the other examinations of the systemic examination were unremarkable. Nasogastric tube was done to aspirate the gastric content, and it was just gastric content. And the pictures on the right side shows the type of the mushrooms, which was informed by the family members, and the photos down there was the mushroom which was cooked in the soup. Okay, so next, this is the investigations done, and full blood count has shows there is raised white cell count at 14th. Otherwise, the HB and platelet was normal, and renal profile, liver function 10, coagulation profiles were all normal. Serum electrolyte were normal as well. CRP and also creatine kinase were all normal. Urine for drugs was negative, and ECG shows normal, which sinus rhythm. CD brain was also done in view of the altered conscious level, but it shows normal findings as well. So the impressions for this case was altered sensorium, possibly due to mushroom intoxication. And however, we can't rule out the encephalitis because the patients presented with vertical gaze palsy, which was pathological. So the management given to the patient was IV roxapine and also IV escovir, and she was hydrated with 4 pints normal saline over 24 hours. She was also on GCS charting, and she was on observation for 1 day in the ward. After that, she regained consciousness and was discharged well without any residual symptoms. So this is a case of mushroom intoxication. So we would like to invite the panelists to give us some comments on this case. So maybe we can have Dr. Rachel.
Yes. Actually, this is an interesting case, though when I look at the ceftriaxone management, but I guess there is a consideration of some infectious processes that is also considered. But for mushroom poisoning, based on my experience and readings, if the symptoms will be resolved for within 6 hours, then it might be a group 7 kind of mushroom, which is a gastric irritants. But if the symptoms will be prolonged 12 to 24 hours, there will be still symptoms, then we might watch out for the liver and kidney, because it might be a nephrotoxic kind of mushroom or a hepatotoxic kind of mushroom. But in our here, we really ask the patient and identify the mushroom that would be the first approach, so that we will rule out if that mushroom contains amatoxin, which is very hepatotoxic. So we will suspect for amatoxin because the patient identified as so, then we will do and retrieve that mushroom and then do the Mexner's test, wherein there is you get the juice, 1 drop of juice, then hydrochloric acid in a filter paper, then you have that blue discoloration after the drying of the mixing of the hydrochloric acid and the juice of the mushroom. Yes.
Okay, thank you, Dr. Rachel. Maybe you can have Dr. Mashita to give us some insights on this case.
So especially in so-called we are approaching a patient with a general approach of Horizon's patient, it is again, I did mention it following the snake bite just now, it's easier for you if the patient able from this case. I'm sure the father is well versed with the condition of the patients, where he did mention regarding the patient, he is aware of the patient might have a complication, might have something to do with the so-called this mushroom that the patient took after for quite some time, that the patient developed kind of symptoms related to the mushroom ingestion. It is easier for us to approach this kind of patient as we know the so-called the substance that already been so-called given to us. But in a situation where we do have some sort of patients where they come to us with just a history of nausea, vomiting, giddiness. So that's why we have to again to emergency department, you do have to approach the patient accordingly. Resuscitation ABC is always the main so-called approach in any patient, especially in poisonous patients. So regarding this mushroom poisoning, it has a various so-called effect. Even though the patient able to tell you that the patient is actually having this symptom after he took some sort of mushroom, again the so-called the identification of mushroom is also very challenging lah. Okay, so most of the time if we able to get the samples of the mushroom, and then we can actually here in Malaysia we do have this Rex team again, Rex team. We can actually consult Rex team, and then and what you should do is, I'm not sure either in this patient the reason for putting in the rice tube is to get the sample, is it?
Yeah, I think the gastric, the NG tube insertion is for the gastric aspiration.
So I'm not sure either it is recommended in such poisoning to put in rice tube, is so called to get these samples of gastric content. Is it recommended, Dr. Carl or Dr. Chu?
No, I don't think so. It's not necessary, because if you look at the time, what is the time? Sometimes the issue is you cannot identify. If you want to aspirate for morphological, most of the time it's already digested, so it's not really going to do anything. And we are not testing the chemicals in the gastric content to diagnose which mushroom, right? So for identity of mushroom is basically mushroom poisoning is secondary. What we should be doing is looking at the syndrome of the patient, and we treat accordingly. That's why close serial monitoring and then the liver function test all will. Sometimes this may not be appearing abnormal early. It can be presented a bit later, yeah? Especially for like Amanita mushrooms that cause liver failure. So there is a process that we should do, as at least in Malaysia, for each mushroom poisoning. Maybe Chu can tell us more, because there is going to be involving other institution or other bodies, like the family, not family medicine, but public health, and how to sample the mushroom for identification. Maybe you can explain a bit more about that.
Sorry, Prof. I'm not so sure about the details, but because they are actually they are making a new guideline, like because now we have a snake bite guideline, and we also start to have a jellyfish guideline. They are in the process of making a guideline for the mushroom poisoning in Malaysia. So there are a group of people, and also they are teaching people how to the healthcare personnel how to do the sampling, and also to notify the disease to the in the guideline, but still in progress. But for us, if we want to, let's say if you have the patient come to you with this, try to ask the patient for a uncooked sample, because the cooked sample actually are not helping much. So we try to ask for the patient or the family to provide us the uncooked sample. And of course, the more we got is better, because once we send the sample for identification by the professional person, there's some of the mushroom they will need to cut half to see the cellular view.
It's by morphological identification, right?
By
It's
morphology.
done by maybe a mycologist.
Yeah,
So
mycologist.
we have, yes, and we have sort of like established that. But then it is kind of academic in a way, because it doesn't really, it's going to take time, and you know, it's not going to be an immediate identification.
Yeah.
And for sampling locally sampling, the public health have to go to the site and look at where they collected this wild mushroom, and then collect from there and send for identification. So that's one. But the most common mushroom poisoning in Malaysia is from chlorophyllum, CM, chlorophyllum molybdites.
Yeah.
So most of it is because causing gastric irritability. And then we have to consider also the timing of the symptom. If the timing of the symptoms, let's say the GI symptoms is early, less than 6 hours, then we are most likely just dealing with GI type of irritant. But if the symptoms present a bit later, more than 6 hours after ingestion, then we probably be dealing with, for example, Amanita type mushroom. Okay. So and neuro mushroom like psilocybin and so on is not uncommon. I'm not sure what about the traditional use of psilocybin mushroom in Sarawak, but there are people using it in Sabah and also for recreational use. I'm not sure what is the status, whether it is illegal or not legal to use it in Malaysia at the moment. Maybe the guideline will help us, you know, understand this situation more. What about in the Philippines, Richel? People use mushroom for recreational, or people
Yes, yes.
go out hunting mushroom. It's not a
Yes,
culture. It's not a culture. Hunting mushroom in Malaysia is not a culture. But you go like France, Germany, maybe Australia, public will go out hunting for mushroom. They're seasonal for it. Even Japan. And that's one of the commonest cause of poisoning as well. In, if I'm not mistaken, in Western Japan or Northern Japan. Some part of Japan, fugu poisoning is more, and some part of Japan, mushroom poisoning is more. Yeah, it's quite interesting demarcation there. Right. What about Philippines again? Sorry, your response?
Yes, sir. Yes, sir. Actually, the psychedelics, the magic mushroom, no, some of our teenagers here that cannot afford any stimulants like methamphetamine or any stimulants, they go for the hunt of the mushroom, wherein it will grow mostly in a dung of a cow or a carabao. So there's a lot of what do you call this one, psilocybin mushroom poisoning secondary to psilocybin intoxication. So teenagers would have a restlessness that just like any stimulants that have a dilation of pupils. Some were having seizures, and also some were having acute psychosis. So that is the most common presentation of the psychedelic mushrooms or the magic mushroom if intoxicated. Usually they will mix it in a soup or any noodles, then the mushroom. That's the usual case scenario in our hospital. Talking about also in the nasogastric tube, we use that one especially if we suspected for prolonged symptoms wherein there is benefit of charcoal, and then patient is vomiting. Then actually if we have a suspicion of any amatoxin, um, because amatoxin will go hepatic recirculation. So there is a benefit of multiple dose activated charcoal. But then the through nasogastric tube in order for to also avoid aspiration, because if you let patient drink the charcoal, some will not tolerate the activated charcoal. But usually it is given, the multiple dose activated charcoal is given only in a Amanita phyllodes mushroom poisoning.
Thanks. Thank you so much for the feedbacks and also the insights from all the panelists. So we have one question from the floor from Yushen Teo. So may I know what is the significance of knowing the species of mushroom in our management?
Maybe I can answer.
Yeah, sure.
Yeah. Um, in my own opinion, and also when I manage mushroom poisoning, I always refer to, though it's in old book, the Gerald Lycan. It's a toxicology manual wherein there is a grouping of mushrooms. So there's a lot of mushroom actually, and then if you identify the mushroom, it contains a certain toxidrome. Like the psychedelic, it is in group 6, wherein the psychedelics are stimulant, just like LSD. And then if you have this gastric irritant mushroom, it's in group 7. And in group 1, cyclopeptides, that is amatoxin is there. So there are other that are nephrotoxic, like group 5 and group 8 are nephrotoxic. So you need to identify this mushroom in order for you to, especially if the symptoms is prolonged, more than 12 hours. So you really need to identify this kind of mushrooms so that you will be guided in your management also.
Okay, thank you so much, Dr. Rachel, for the answer. So, I think that's all for this case.
Okay.
So once again, thank you everyone for your thoughts and your questions. And thank you to our panelists for your fruitful comments and inputs throughout the sessions. So next up, we have prepared a quiz with a special prize for the winner. So later, Prof. Khaldun will share the Kahoot quiz. So all participants are welcome to scan either the QR code or key in the pin in the Kahoot to play. And at the end of the quiz, we will display the QR code for feedbacks and also a link for e-certificates. So please stay tuned.
Number 3. Number 2. And the champion. Sanyong. Congratulations, Sanyong. Please give your details to our organizers, and we can give you your prize after this. Okay, so I think that's it. Thank you so much.
So congratulations and well done everyone for your effort. So to the winner, please reach out to any of us, any of the secretariats, so we can give you the present. Okay, so for our closing remarks, please join me in welcoming back Professor Khaldun, Prof. Khaldun, and without further ado, the mic is yours, Prof.
Oh, you want me to do? I thought you're one of the panelists. Okay.
Okay, sure.
Well, thank you so much for being with us this afternoon. I hope everybody had a fruitful discussion and learned something throughout this program. I hope, I'm not really praying for you to get cases, but at least if you do get such cases in your practice, give some idea. And I think most importantly is also information who to call when you are not sure of how to manage cases. So in Malaysia, we have REX,
So you can communicate with Rex when you have cases in your hospital, and we will try our best to help you. For example, today we had several cases in Sarawak, which are very interesting, and it may be involving foreigners as well. So there's a bit delicate in dealing with such cases. Okay. All right. So that's all from me. Hope everyone will get their certificates. So I'll pass back to our moderators, and hope to see you again next year for the series number 4 for our clinical toxinology, if there are any. Okay, we're just hoping that it will be continued. Okay, thank you so much.
Thank you, Prof. Khaldun. And once again, thank you so much to our panelists, Dr. Mashita binti Muhammad Ismail, Dr. Ruchel A. Simini, and Dr. Kim Chul Hoon. And it was an eye-opener to hear from the views of the experts. And we truly appreciate your time for sharing your opinions with us. So now we'll display the QR code and the link for the e-certificates. So please do scan the QR codes, and you will be able to receive your e-certificates once you have filled up the feedback form.